So I will talk about the principle of surgery in AIS. Here you can see my disclosures. So this is the plan of my topic. First we will talk about surgical indications, then about the timing of surgery. We will talk also about classification, and then when surgery is decided, we will try to decide which curve should be fused, especially when we have more than one. And after that, we will talk about fusion limits, surgical technique, and at the end, we'll talk about errors, principal errors which can be avoided. As surgical indications, we should know that the magnitude of the curve is one of the major surgical indications, but not only that, it's also the location of the curve. Thoracolumbar curve are much more surgical than thoracic curve or double major curve. Another indication is correlated to the risk of progression when orthopedic treatment is not effective or when the risk is still at zero with major curve. The timing of surgery is a balance between the growth velocity and the progression of the curves. So the best time is when we are above or after the peak height velocity, but we are not so far in the slope P2 for progression. We can see the timing here with the green arrows, and it corresponds usually to research 2. We have to know also that we have many parameters of growing. So we have triradiate cartilage, and we do not recommend to do spinal fusion when triradiate cartilage is open. In this situation, probably it's better to do growth-friendly technique. We have another growth parameter, and especially research sign. The advantage of research sign and triradiate cartilage measurement is that we can see these parameters on the same X-ray used to evaluate scoliosis. So we don't need to do another X-ray to check growth when we are using these parameters. So the timing of surgery is a balance between curve progression and the remaining growth. The surgical indication in research 0 and triradiate cartilage is not to do fusion, but growing growths. When triradiate cartilage is closed, if it is possible, we should wait until research 2 to be on the safe side concerning growth, remaining growth. If it is not possible, we can do fusion when triradiate cartilage is closed. If the research sign is 2 or more, we can directly do spinal fusion. What we should know about classification is that classification changed with time, and classification is usually associated to the surgical technique used at the moment of the classification. What I mean by that is, for example, King classification was associated to Harrington technique. So for each type of King, Harrington proposed a specific treatment. And now the most used classification is Lenke, and it's correlated to the CD segmental correction technique. The Lenke classification need four standard X-ray, as you can see here. It divides the curves to structural and non-structural and major and minor. I think all of you know the classification of Lenke, and which is important is the lumbar modifier, which help to decide about the distal level of fusion, but also the medial sacral line, which help to decide also about the distal level of fusion, and if yes or not we have to fuse the lumbar curve. We will discuss in detail about that. The limitation of this classification, as all of the classification we have advantage and limitation. So the advantages are that it is high reproducible. The author recommend to fuse major curves and structural minor curves, and non-fusion for the non-structural curves. But some exceptions exist, especially on the lumbar spine, because some minor structural or even major lumbar curves could not be fused. So this is one of the major limitations of the classification. I think in practical way, when surgery is indicated, the first question we have to ask is which curve should be fused. It is not possible to talk about fusion levels before deciding which curve it should be fused. And very often, I think it's really, on practical point of view, is very often we look to the curve and we decide the levels before deciding which curve should be fused. And this is a big error. I will show you why in some examples. So when we decide which curve should be fused, then we will decide which level should be fused. So this is very important to go in this direction and not to start by choosing the levels. The level should be fused. The major curve should be always fused at least from cup to cup. So this is very important. We should not fuse less than the entire curve. So this is very important. But the exception of that is sometimes in the lumbar type 3, Lenke type 3, so double major curve, sometimes we don't fuse the lumbar curve. This is exactly the same in some structural lumbar curve in type Lenke 1C, we don't fuse them too. So we can see that the curve which sometimes could not be fused is the lumbar one and the lumbar curve, and of course because of the flexibility of the segment and the importance in adulthood of the lumbar mobility. So when we decide to fuse a curve, we should not include, if we decide to do a selective fusion of the thoracic curve and we decide not to fuse the lumbar curve, it's very important not to take more vertebra in the lumbar one, which means that we have to limit our fusion to the main curve without including some vertebra from the other one. Otherwise, we will stop on the apex of the lumbar curve and we can have progression of it. Second, we have to know that improvement may occur with time. So if we decide to do selective fusion, we should wait to see the result, and the immediate postoperative X-ray is not reliable on that. And we have to inform the patient about the possibility to do another surgery if needed. When we decide which curve should be fused, then we can decide the fusion limits. First of all, we have to cover the entire curve, and we have to stop on minimally rotated vertebra. We can check on the bending film on that. The upper instrumented vertebra should avoid the apex of the thoracic kyphosis, so we do not recommend to stop on T7 or T8. The lower instrumented vertebra should be touched or close to the medial central sacral vertical line. And we will talk about two specific cases, Lenke 1C and Lenke 2. Let's start with Lenke 2. In these cases, when we have upper thoracic curve ending lower than T6, when we have kyphosis between the two curves, when we have more than 40 degrees or more than 30 degrees on correction films, left shoulder up, when we have T1 oblique to the right, we should include the upper thoracic curve in the fusion.